on to our next session before the great debate, and this particular session is looking at service delivery innovations, and we've got 4 quite different presentations, and I'm hoping people can come up with some questions, particularly around the issue of, you know, whether these sorts of innovations might be appropriate to transfer to other health centres, for example, and particularly the issue around sustainability, I think, is a really important one as well for these sorts of innovations that we're going to be hearing about this afternoon. So we're starting with Graham Bell, who's clinical nurse at Wollongong Hospital, and he's going to talk to us about medication incident reduction at Illawarra Cancer Care Centre.
My name's Graham Bell. I'm the clinical lead at Wollongong Hospital. Just thought we'd have a beach off with Newcastle. Picture there. That's us looking up towards Sydney. So, yeah, just a lovely place to live.
Newcastle wins hands down.
I don't know. So, look, I'll just sort of go through what this talk's about. Basically, we've improved safety and efficiency of cancer service delivery to patients through the use of standardised current evidence-based best practice peer-maintained cancer treatment protocols, or the EVIQ protocols, and the use of information technology initiatives including electronic prescription, administration, scheduling and clinical decision support. I also want to talk a little bit about, I guess, the ability these systems give to sort of capture, collate, store and share data, which is a bit on the back of Amy's talk earlier this morning. So the Australian Commission of Safety and Quality Healthcare estimates that 2 to 5% of Australian drugs contain prescribing errors, and administration errors occur at about 5 to 18%. Chemotherapy medication incident has the potential to cause significant mortality and morbidity. Chemotherapy medications possess a narrow therapeutic window and associated with potentially high incidences of toxicities, even if we're giving them at therapeutic doses. Chemotherapy can be complex. The same drug can have variable doses dependent upon...
Good afternoon, ladies and gentlemen. This is Fire and Rescue New South Wales. Just informing you that we have investigated the previous alarm and have deemed the area safe. You are now free to return to your normal activities. Thank you for your cooperation.
Thank you. I was worried there, but yeah. So basically, it's complex, and what can we do to sort of make it safer? So every error is potentially tragic and costly, not only for the patient but also for the health professionals involved. And it's particularly true when the error could have been prevented. So this is just to sort of give you a picture of medication errors across my district. You can see there that the big 3 are prescribing, dispensing and administration. So very common, and it'd be a common picture across the state and across the nation. Our problem, I guess, is how we're looking at it here, is that our medication charts were handwritten and, as usual, illegible, had incomplete information, so height, weight, blood results weren't in there, differing dosing practices dependent from the medical oncologist or haematologist, and we didn't have an agreed upon sort of chemotherapy protocols, so our supportive medication therapy, antiemetics were all over the shop as well. Also required error-prone transcription of protocol each time we needed to put on a new medication chart, so Folfox would have to be put on multiple times. So here's a referral. This is pretty normal, I guess, for us, or used to be. I blanked the name and address out, but that was illegible. The diagnosis is pretty hard to read. We don't have, well, the height's 4'10" centimetres. I knew this gentleman. He was about 6'1", which made more sense around 120 kilos. But, you know, there's an incomplete sort of picture we're getting here about what drugs and where errors can occur. There's no creatinine level there, even despite the gentleman being on carboplatin. So if we have a look at this is Illawarra Cancer Care's medication incidences. So the blue is our medication incidences, and you can see that over 50% of our IMS incidences are related to medication. If you have a look at, if you break down those incidences, you can see, apart from drug reaction and extravasation, pretty much all the other IMs are preventable with the introduction of an information system. So we decided to use an information system, and it would help us reduce the amount of medication errors. And indeed, Safe Medicine's practice state that electronic prescribing with proper systems design, implementation and maintenance can contribute significantly to the prevention of medication errors today. I underlined and put in bold the proper systems design, implementation and maintenance, because if you don't have it, it doesn't work, and you'll get the same problems that you had before, just in a different part of your system. So we also decided to use standardised chemotherapy protocols. So we used EviQ chemotherapy protocols with a view to standardising prescription process, provide predictability, support accuracy, enhance the workflow by decreasing ambiguity and reduce errors. So that was our driving force, that reduction of errors. So as a key foundation, we went live with this in December of 2010, and it was used to advance towards completely paperless, patient-centred process. So we built New South Wales, as I've probably mentioned, EviQ protocols into the system. We had an area-wide agreement, so all the doctors agreed to this. And prior to obviously getting them live, we had a group of clinicians, nursing, pharmacy, doctors looking at each of the protocols prior to approval. And we built in substantial clinical decision support within the system, so to help the clinicians. We now have a complete electronic record for chemotherapy prescription, administration, scheduling, pharmacy ordering, patient assessment and clinical documentation. I guess I might talk a bit later about patient assessment. I think it's a big area that we probably need to be discussing, and I think what Amy Abernathy was talking about earlier as well is that ability to collect live data, and it's a big tool that we should start to be discussing and using. So this is now our order, and that's just an ACT order there, but you can see we have, I'll just see if I can use this. Blood results are fed into the system. All the OBS are there for the docs to see, height and weight, VSAs in there as well, and some of the toxicities as well, ECOGs entered each time. So it gives you a good overall picture of the patient. If you compare that to an old paper referral or paper prescription, it's a marked change and a marked improvement. So outcomes, what happened when we introduced this system? We hoped for a 50% reduction. We got 63% reduction in medication incidence, which is pretty large, and we were pretty happy with. And this was at a time that our overall occasions of service continued to rise. So, and despite having that overall occasions as usual in health, we didn't get any extra staff. So you can see increase in workload, decrease in IMs or incidences. So pretty happy with our results. One of the sort of unexpected results was that we also saved money. The standardisation of the protocols resulted in a 56% reduction in IV on Dancitron. Before it would depend on the oncologist who got Zofran and when they gave it. So we saved about $3,000 a year on the IV. We also reduced our oral on Dancitron. If you think about the flow on of that as well, you decrease problems with constipation, those sorts of things also. We'll save about $16,000 over 5 years on oral on Dancitron. So not only made it safer, we saved money, which makes the bean counters happy. We're now aiming to get this into the inpatient setting. Our current aim is to use a printed report from the OIS, which a lot of other services do in the outpatient setting, and we'll replace the purple medication chart there. We won't use it to prescribe any other medication, which we don't want to step on EMR's toes. And once we sort of nail down any teething problems, we'll look to get it completely electronic on the ward also. And that's just a printout of one of our ward medication charts. You can see it's pretty messy, but again, it's legal and it's safe, apparently. This is the new version. So now we have the diagnosis up there. We have what we're giving, height and weight, the cycle, any special instructions for the drug. The doses here, the dose bases, BSAs, and again, any special instructions that you want to put in there, you can build it to however you want to. So what are the benefits of bringing it into the inpatient setting? Well, again, you get the gain in patient safety. We have one central location for all patients' oncology treatments, so we're not having it on paper on the ward and then the patient has cycle 2 in the outpatient setting in the electronic setting. It's all going to be electronic from the start. It also ensures that we use standardised EBQ protocols, so it makes it more difficult for doctors to treat off EBQ, I guess. All vital information has to be provided before you can prescribe, basically. The doctors, and this is for us as we have a satellite in Nowra, can prescribe remotely, so if they're down doing a clinic in Nowra and they need a patient to start chemotherapy, they can prescribe it remotely. And again, all the supportive care is built in within the system. Future, where do we go from here? I mean, it's a gateway to further information system-based projects, and again, Amy spoke quite thoroughly to that. It was pretty impressive. Cancer Services, we're formalising ties with the School of Computer Science and Software at Wollongong Uni. We hope to have a formal person appointed at the university co-chaired with us. We're looking at electronic scheduling to improve scheduling efficiencies, or automated, that should say, scheduling for improved scheduling efficiencies for patients in the oncology daycare. Automation of patient triaging, so taking, I guess, the God factor out of who you decide gets treatment before the other. Electronic rostering of staff dependent upon the workload of the system. So all these things are possible with the use now of an electronic system. And the beauty of it is we now have nearly 2 years' worth of data that we can pull, because that's how long we've been electronic and how long we've been capturing our data. We also successfully completed a project assessing feasibility of automatic data extraction to a central location, again with the Cancer Institute. This will hopefully allow for benchmarking with other districts, collation of baseline data for comparison with new treatment protocols. And again, back to Amy's talk, here is the boon for everyone if we can collect and collate data from all our electronic systems and get it to one spot. Your problem is how you're going to get it out of your system. You can can a report, but the report will change at each site unless you get the vendors on board to actually build the assessment to put that in exactly the same location in the database, so you can have the one report for the Cancer Institute. So we probably need some collaboration and then the Cancer Institute to kind of mandate what we're going to report. Your diarrhoea toxicity could be different to my diarrhoea toxicity. Do they use CTCA? Do they use WHO? You know, we've got to discuss those sorts of things as well now before we muddy our, what was it called, the soup, the data soup. I'd probably prefer it to be called a pool or a river, because then, you know, you don't want to swim in polluted water. And I think we need to keep our data clean, and we have to start talking about that now before we get too far down the line and before everyone starts using these systems and having their data in all different spots. We're also looking at reflecting what we actually practice. So if you have a scheduled appointment for, say, Taxol, you say, oh, patient going to be, what's Taxol take, an hour, half an hour for assessment, everything, they're going to be for an hour and a half. And EBQ has suggestions as well on how long an appointment should take. What you find in reality is that doesn't happen. So you want to reflect what your practice is. It starts to implicate workload issues. So a nurse who's thought, oh, I'm going to treat this patient in an hour and a half, they're still here at 2 hours, there's a patient waiting upstairs for that chair. That gets a nurse stressed. Then they've got to get a cannula in, they're stressed, they miss the cannula. It's a flow-on effect. So if we can start to reflect actually in real time what we're doing, then hopefully it improves our workflow, improves efficiency. Thank you. That's it. So any questions?
Thank you, Graham. So we've got time for a couple of questions, if people have got questions. Well, while people are thinking, I'll just ask a quick one. I guess coming back to Amy's point about missingness, the extent of data capture, I suppose. Have you been able to look at that yet at all to see the extent to which those forms are completed fully enough to be
informally, yes. We've got funding for 2 separate projects from the Institute to automate an audit for that. So our ideal, we want to improve staging, basically, and a diagnosis input. We want to get that right. So we want to get a report built by an analyst to enable us to do that. So, but we're looking at things like diagnosis, ECOGs administered, the right chemotherapy protocols given to the right diagnosis. It's another issue that you'll find is that you'll have a patient with 2 or 3 diagnoses. Accidentally, the doctor gives it to the wrong diagnosis. So someone had lymphoma and now they've got head and neck cancer. You might find that we're giving, concurrent cisplatin to a patient who had lymphoma, which is not true. It's to the head and neck. So there's a few reports that we want to automate to make sure our data is clean.
Yeah.
Then we'll look at overall survival, that sort of thing, the follow-up appointments, how we can improve the collection now, which I think is another big area that we need to start looking at. And I don't think we collect at the moment very well at all at our centre anyway. So I hope to get some of those automated, and we'll get some real-time data, and then the idea is to start sending them out, obviously without the doctor's name on it, but saying Dr. A fills out their diagnosis well 50% of the time, where Dr. B is doing it 100%. Yeah. Then they get rivalry.
Yep. Feedback helps.
Yeah.
All right. Thank you, Graham. That was terrific. Thank you. Okay, so now we've got Kerry Clover, Research Manager at Newcastle Mater Hospital, talking about screening for pain and distress using Quicker Touch.
Thanks, Afaf. The first thing I'd like to do is acknowledge the other people that have been involved with Quicker Touch, particularly Kath Adams, who was very heavily involved when she was working at the Mater. And she's on a couple of slides around today. And also I needed to thank the Cancer Institute, who gave us some startup funding. So we're very grateful for that. I'm going to have a crack at this. Oh. Wrong way. Okay. So I'm talking about pain and distress. I won't spend any time defining pain, but I'll just briefly define distress in case it's there are people here who are less kind of obsessed with it than I am. So it's an umbrella term for a negative emotional state, and its origins can include physical symptoms, it can come from the social environment, or mental health symptoms, and it's seen as existing on a continuum from a normal kind of functional level that anyone might experience to a level where you're getting some kind of impairment in your functioning. Yeah, how's my short-term memory? So if distress is untreated, there's a lot of quite serious consequences. People are obviously suffering, they have a lot of somatic symptoms, and I'll just let you read those. I won't actually go through them in the interest of time. Okay, so both pain and distress are really common for people with cancer. They're also both treatable. There are things that can be done to help manage them or ameliorate, and they're often under-recognised. So research has shown that as little as 10% of cases of depression can be recognised by an oncologist in a busy oncology practice. So what to do? So people then have suggested that screening, and in this context we mean asking all patients about pain and distress, and that they be considered like the 5th and 6th vital signs. So vital signs, as probably everyone knows, is things like respiration and body temperature, things that you monitor all the time in clinical care. So they're trying to get these things in there as the 5th and 6th vital signs. And if that kind of screening combined with appropriate kind of management or response to that screening, it's been recommended by a whole bunch of bodies internationally and also in Australia. And I note that the NBCC is now the NBOCC. Okay, so what's Quicker Touch? Well, it stands for Quick Customised Assessments Using Touch Screens. It's computerised screening for pain and distress. In our Quicker Touch model, we had a paid screening assistant will come to was in the oncology outpatients department and would assist people to get started on the assessment. So I just said there. Okay, so when we were putting it together, and it's a bit like Amy said this morning, I think she used the word efficiency, I'm using the word brief. We just knew that it had to be brief to have a chance of working in clinical practice. And we've got it brief for the patients as well as the doctors as best we can. So the questions that the person gets asked are in like a two-step process, depending on what they say. The first level, if they look fine, they stop there. If it's there might be a problem, that's explored in a bit more detail, and I'll explain that a bit further. And so we also have customised printed feedback, and that's used in real time. So it only prints out if there's some suggestion that there's a concern that the doctor or clinician might need to act on. It's in time for the consultation, so they're done while they're waiting. It's ready in the patient's file when the doctor sees them. The results are like on a single page, they can just glance at it, and I'll show it to you in a second. It's got a recommendation kind of for the action that the doctor could consider taking. And that verbal notification. In some cases, the screening assistant, if there was like a particular case, they might actually go and talk to the doctor or the nurse as well as having the piece of paper. So some of the other features of Quicker Touch, the multidisciplinary team members can access results electronically, they can log on to it, they can set up email notifications, they can have like lists of their own patients, so that any time one of their particular, like if it's a cancer care coordinator, any time one of their lung cancer patients, say, is screened, they can get an email, or they can get a weekly summary of their patients. It's web-based, so that once you've got it on, for us, in the intranet, you can access it from any computer inside the Area Health Service. And it can also run multiple surveys. So, yeah, it can do all of those things. We've also got, for example, we've got a caregiver screening module, and it monitors caregivers' distress and their satisfaction with service for their loved one. So this is a flowchart of the questions that we actually ask. So there's a bit of identifying who the patient is. Then I'll just take you through the negative thing. Okay, so we get some ID. Then people are asked if they have pain. That's on a pain thermometer from a score of 0 to 10. If they have any pain at all, so 1 or more, they're asked if they want help, and then a clinician alert is generated. Whether or not they want help, the clinician alert still kind of happens. And this is the kind of, this guideline comes from the NCCN in the US. So if they say no to pain, they come down here, they're asked the distress thermometer, which is 0 to 10 scale again. If they say no to that, they're finished screening. So they can go no, no, done. That's screening. That's most people, and that's as long as it takes. If you've got the positive thing, so 1 or more for pain, want help, clinician alert, same for distress. Asked if you want, if you just score 4 or more for distress, then you get this second step that I was kind of talking about before. So you've got a problem list, which is 35 items, which is physical symptoms and psychosocial concerns that goes with the distress thermometer. They're asked if they want help with their distress, and they're also given this Psych 6, which is a 6-item questionnaire that's got more specific questions about kind of depression and anxiety and the sort of thing that you might come to, say, a psycho-oncology department for. Again, they're asked if they want, whether or not they say yes to this help, the clinician still gets a printout, and it reflects on there. Well, I'll show you what it looks like in a sec. Okay, so this is what it looks like. It's pretty quick to look at. So you've got your distress and pain scores. You've got what we think could happen as a result, so pain assessment or consider referral to psycho-oncology. Oops. And it's even got a little thing here to say if the patient wants help, just to add a sense of urgency. And it's got, oops, what have I done? Button. Nope. Sorry. It's got previous results, so you can see if the person's on an improving or deteriorating trajectory. And it's got it'll have a list of as many problems as the person's indicated down here. There's a space here for people to, for the doctors to tick what action they've taken, and they can sign off on that. But in the spirit of honesty, I have to say that didn't really get completed all that often. Okay, so I'm going to just talk quickly about the clinical outcomes. So this is preliminary data from 4 years of Quicker Touch, and it's on the feasibility, overall prevalence, and prevalence over time. So this slide is the cumulative number of occasions of screening and patients that have been surveyed over the 4 years of the project. So from October 07 in 3-month intervals out to 2011. And so you can see that we've had over 26,000 occasions of service or occasions of screening, and close to 9,000 patients have taken part. So we take from that it's quite feasible and acceptable to do screening this way. And I think we did a sub-study, and about 9% of people kind of declined to take part in screening. But other than that, it's quite well accepted. This is the overall prevalence of pain and distress. So you can see, I think the first thing to really note about this slide is that most people are fine. Most people don't have pain or distress. So often when you talk about introducing screening, people are a bit overwhelmed, they're a bit frightened that they're going to be just swamped. They're going to have to send everybody to see a psychologist. Not going to happen. And you can see the varying kind of levels of pain and distress only. The other thing to really note about this one is this Psych 6. So these are people over threshold on the Psych 6 who might be considered as possibly needing to come and see a psychologist or someone specialising in psych-oncology. So that's only really 6% of people. So, that idea of it being Pandora's box, probably not supported. And that's, I should have mentioned, that's the 9,000 people, and that's on their first occasion of screening, so that's all separate individuals there. Okay, this is my last data slide. So this one was kind of unexpected, and it's really interesting. So this is the prevalence, this is the proportion of people who are over threshold for pain or distress over the period of the project. So in that first 3 months when we started, you can see that the prevalence was here, and as it steadily decreased over the 3 or 4 years, so that it's towards the end it was pretty much less than half of where we started. And we didn't really expect that. So this is for overall, so that's all the occasions of service, but you get the same pattern if you look at just first occasions of screening. So why? So this is observational data, we're very conscious of that. We don't have a comparison group. We do know that it's not due to just really broad changes in patient characteristics, so it's not just all women at the beginning and all men at the end or anything like that, so we've controlled for those kinds of things. It could well be that pain and distress were just decreasing anyway, and that it's continued to decline. But one thing it might be is that it's affected clinical practice by raising the profile of pain and distress, having it come and talked about all the time, every day, day in, day out. So it may have affected practice in that way. But there's no real way to kind of confirm or reject any of those hypotheses at this point with these data. Okay, so all of that was done when we had a paid screening assistant. We had a couple of years of that from the Cancer Institute. We found some extra money for a time. That's on hold at the moment, so we're trying to go in new directions, sustainability. So the cancer care coordinators are still screening their individual patients, and they might do that over the phone when they're talking to people. They might do it when the people come into the oncology centre. The the psychologists are still screening their patients and using that to monitor outcomes. We're negotiating with the Cancer Council New South Wales about having volunteers to act in that screening assistant role. And that's also going to be the model at Tamworth, so we're hoping to roll it out into other areas within the Hunt and New England. There's some other models around for doing this. Some people in Adelaide, in Palcare, have taken Quicker Touch and adapted it for iPad, and they use it in home visits with a 3G connection. And these are models from overseas that have been made to work. So if you'd like a demo, you can go to this website. Please be gentle with it, it's under development. I'm no webmaster, so we're putting more things on all the time, and these are all on the web, these presentations, so I'm sure you can look those details up. And these are, if you want more info, there's some publications that have come out of Quicker Touch. And I just wanted to close with sort of a more general discussion of the implications of this. Everyone's talked about sustainability, and it seems to me that there's no real clear pathway for the translation of effective non-drug treatments into clinical practice. So if you imagine, say, a drug treatment that had even a whiff of halving pain and distress, and where that would be in terms of developing it. So I've just got one last slide, I think. So if we could have the lights down, and hopefully there should be some... There we go. Just relax. Remember, distress will increase your all-cause mortality.
Imagine this was a drug treatment, halving pain and distress too. Scope for profits and patents, a PBS listing too. Imagine all the people live in pain and distress free. You may say we are dreaming, but we're not the only ones. I hope someday that policy changes and that screening gets recurrent fund.
Thank you, Kerry. I was told there was a surprise in this talk, but that's not what I was expecting.
Imagine this was a drug treatment.
Sorry?
My husband.
Oh, your husband, okay.
It's available for
It wasn't the head of
parties.
cancer services or something.
Yeah, not like the NHS at the Olympics.
Okay, time for a quick comment or question. I'm particularly interested in a response from sustainability point of view.
Oh, okay.
The 6% who had a score on the Psych-6, was that 6% of the 25 who got screened in, or 6% of the total 9,000?
6% of the total.
So it's still quite low.
Yes.
Yeah.
Michael back from Northern Sydney. Kerry, and just for the screening assistant, how much work did they have to do, and how much did the patients then counsel with them at the time of the screen?
I think it varied a little bit, but we very much tried to keep it so that really all they did is they'd call the person, take them to the computer, make sure they're a little bit comfortable, put their medical record number and date of birth in so that we had some control over that kind of quality of the data. And then, to the best of our ability, we encouraged them to just let the patients go. They did inevitably get a little bit chatting with some patients, and some people, if they'd forgotten their glasses or they just didn't want to do it or whatever, they helped them, they'd read the questions out and help them that way. So there's a bit of interaction there.
I know the Mater Hospital often looks like the Qantas chicken lounge, but do you think you'd be able to one day get to it where you've just got a number of terminals and people check in for their appointment and they actually then have to fill in a screen?
I think if it's fully electronic, I think that will kind of work. But the problem at the moment is the way we've got it set up, if we have a physical piece of paper that goes to the doctor because it's not connected to the electronic medical record. So at the moment, if we did that, there's no way to get that result of the screening to the doctor in time. But yeah, I mean, I know they do that in City of Hope. The admin people just hand out a little tablet and then the emails go automatically to the various departments, and it's fully integrated like that.
Thank you, Kerry. I think it is one of those programs where a number of groups have tried to implement screening, and unless it's able to be really locked into the system and not have a specially funded person that sits and makes it happen, the sustainability issue becomes a challenge. So, it's definitely a work in progress. Thank you. Okay, our third speaker is Stephen Della Fiorentina from MacArthur Cancer Therapy Centre. He's the director there, and he'll be telling us about oncology patients' emergency assessment outside of the emergency department. Thank you, Stephen.
Thanks. Hard act to follow with the great John Lennon, but I've got my own legend at the end of this, so just wait.
This is a very entertaining session, aren't you? Glad you came here.
So I need to acknowledge the team that put this project together, Denise and Carl from nursing, Di Adams and Denise Lonergan from the medical side, and Elspeth, who was our initial assessment nurse, and we were able and privileged to get one of the inaugural Cancer Institute grants for innovation a number of years ago, and this project's stemmed from that. So Campbelltown's reaching its 10-year anniversary next year. We've got 2 linear accelerators, 9 chemotherapy chairs. We see close to 1,500 new patients between the 2 services, medical, radiation, as well as pal care and haematology, with over 6,000 chemotherapy occasions to service. We're almost completely paperless. We still need to print a chemotherapy chart. We're just about to reach our 1.7 millionth electronic prescription in the next month or 2. And we have a population base of over 250,000, and with the Western redevelopment happening sort of around Camden and Bringelly, we're going to be getting a city the size of Dubbo every 2 years in our region. So in terms of population growth, it's enormous. We're the 3rd busiest ED in the state, Campbelltown Hospital, and we don't have any College of Emergency registrars. So necessity is the mother of invention, and so because of the issue around patient assessment in the emergency department, we thought that there may be another way of trying to have our patients who are on chemotherapy and radiation assessed by staff who are more attuned, and it's their day-to-day job of managing therapy toxicities. So based out of a number of IMS and clinical incidents and morbidity and mortality meetings, there was a fair number of issues that came up through emergency department after hours and in hours assessment of our cancer patients. The main one was around timeliness of fever and neutropenia. It often isn't classified as a high-level triage category, and often patients wait for some time before they're called in for their assessment. Similar to what Graham said around what oncologists do with chemotherapy protocols, there was great variability in the antibiotics used, in fluids, in blood cultures. The local medical staff of Campbelltown, when this was all started 4 or 5 years ago, was a major problem, and so trying to continue to educate very much an itinerant medical staff was difficult. And central line management around PICs and ports remained an issue. Within our own service, we didn't have nurse practitioners or clinical nurse consultants like many of the larger places do. And we know that this program, where patients drop in and are seen by the most senior person, has been happening for many years. What we tried to do was to try to embed it around everybody's, every nurse to get to look after our patients. So we try to remove the single person risk that this often leaves, where you've got one person who's got the knowledge to do the primary assessment and knows what investigations to do and knows what treatment to initiate. So as I've said, the clinical need was to try to improve clinical assessment and management, and we decided to look at the things that we cause predominantly, which is chemotherapy and radiation toxicity. And potentially it could broaden around the symptom control burden of patients with advanced disease, but initially we just looked at the therapy complications. So we wanted to try to implement a drop-in service, an acute ambulatory nurse assessment-led clinic to try to improve the patient care and potentially speed up or even avoid admissions to hospital if we could run patients without needing to be admitted. So these were our aims of the project, and this is what we submitted to the Cancer Institute all those years ago. So we wanted to make sure that the people best skilled and best able to manage toxicity were the ones that saw the patients first. We wanted to try to improve the process, try to streamline it, try to standardise it, and also, if we could, minimise inpatient admissions. That would be an additional bonus. We wanted to also try to reduce the workload in emergency, and then also try to see whether we could formally involve palliative care. as anything, there's always project scope creep, and so bit by bit over the years, everybody that's come to the centre, whether they're on chemotherapy or not, tend to sort of gravitate towards the assessment unit. So without actually planning to do it, it's happened that way as well, and we've had to try to keep up to speed with certain pain and constipation protocols as well. So it was basically a drop-in service. We had to create some set pathways for the nurses to follow, and that was around primary assessment, initiation of investigations and treatment, and ultimately at the bottom, the best trained staff to assess our patients. So we opened a bit over 4 years ago. We're a Monday to Friday, sort of 8 to 5 type service. Primarily the patients are educated when they come to the unit and they're about to start a course of chemotherapy and radiation that this exists, and they're given little cards and telephone numbers to call us during hours, as well as the standard present to ED if they have problems after hours. And we, the oncologists, were also instructed to refer patients if they were in a clinic and they happened to have a particular symptom that we knew was going to take up a period of time, rather than us try to run it in the scope of a clinic. We just moved them down the corridor, another sort of 10, 15 metres, for the nurse assessment unit to manage them, and then we would review them after the initial assessment was done. The main aspect of patient safety is that if they met clinical criteria around patient reviews, low blood pressure, hypotension, hypoxia, delirium, loss of consciousness, if they were really sort of critically unwell, we didn't have the acute resuscitation initially to manage those patients, so they would have a MET call and or transfer to emergency, or if it was a telephone triage, then they'd be advised to call the ambulance and go to emergency. So we decided to pick on these at the moment: febrile neutropenia, chemotherapy, emesis, chemotherapy and or radiation, mucositis, enteritis, esophagitis, and the very fortunately rare complication of spinal cord compression. So we met over a number of months to try to get everybody on board. We met with ED because we were going to, they needed to be aware that we were going to have patients that we would eventually need to transfer up to them if it was going to be near the end of the day, and also then to give them the tools for them to start to use these clinical pathways after hours. Over the years, we gradually developed our own little mini resuscitation room with oximetry and bladder scanners and ECGs and everything short of a ventilator, bit by bit through philanthropy and a lot of local groups helping us. And then we decided to collect some data contemporaneously through ED as well as through our own centre. So this is just a bit of an assessment around a febrile neutropenia clinical pathway, where down the left-hand side are some set assessments that the nurses will do and record, and then some things around on the right-hand column, what if the patient meets a medical emergency criteria, what to do. And so these exist for all 5 of those pathways. And then around the aftercare, if the patients are going home, if somebody has got fever and neutropenia and they're low risk and they can present the next day or 2 for reassessment and they can go home on oral antibiotics, then there is a set follow-up protocol that we can run them outside of the ED, and there are phone consultations, whether they're admitted or not, just to sort of follow up on their symptoms. And then everything's documented in our electronic record. So we decided that these were going to be our sort of measurements, our KPIs. First of all, how long would it take for the patient to be seen primarily? When was the treatment initiated? And as many of you know, the Clinical Excellence Commission is about to roll in a sepsis kills pathway, and time to first antibiotics and time to first fluid is going to be one of their measurements. How long did it take from coming to the place to getting a ward bed or going home? What were the proportion of admissions to presentations? And then, as I said before, we would compare contemporaneously the ED data and then look at patient and staff satisfaction. So over a sort of a 3-year period that we sort of collected, and we chose sort of 3 fairly random months in ED to try to get a bit of an idea about when interns and RMOs are at the beginning of the year and the middle and the end of the year, rather than doing it all in the January, February, where generally it's a chaotic part of the world, EDs. Not that it's not normally. So over a 3-year period, it's about sort of 700 patients a year. In addition, there are a lot of extra phone calls, either for initial triage or for follow-up. Now, I haven't put statistics on these because they're not really randomised, and so there are issues around when the data is collected, and but it gives you a bit of an idea of speed of things. So really, the good thing from ED is that these toxicities are now being recognised as more medical emergencies. So they're all sort of seen early around triage. The downside still happens is around when that treatment is initiated. When do they get the antibiotics? When do they get their analgesia? And then the time to the ward bed, the old EAP remains poor. We were able to do it within the magical 4 hours, but again, there are reasons for that. So if you look at the new measurement of NEAT, the emergency access times, we do pretty well. The hospital itself, less so. But because we close at 5 o'clock, then our patients are preferentially given ward beds. So there is a positive bias in that, but probably not enough to account for that 50% difference. Our admission rate is low compared to ED, and again, that may be because we're moving some of our higher acuity patients across to ED, but also I think it also reflects that if people come after hours and it's 11 o'clock at night, then there is probably a lower threshold from families and carers to have that patient admitted overnight and then discharged the next morning. We do audits on the compliance to the clinical protocols, and we're pleased to say that it's 100%. And we've managed to rotate our RNs through the assessment unit, and so we've now got 5 RNs who are able to provide this service, and that provides a redundancy that leave often causes us to worry about. Satisfaction's good, very good to excellent. So we initially got 12 months of funding from the Cancer Institute for the RN, and then we decided to roll it into core business. And so just like our nurses give chemotherapy, do radiation assessments, come to clinic, they now come down through the assessment unit. And then this year, as I said before, we were probably averaging about 900 a year in the first 3 years of the pilot. In the first 8 months of the year, we're averaging almost 200 presentations a month, and there are 387 different individuals that we can identify who have gone to that service. As Afaf mentioned, transferability. As I said, we can roll it out into palliative care. Other cancer centres have been chatting to us about trying to borrow our protocols and use it in their centres. And the protocols and the staff education that we do is transferable. And certainly in our hospital, we're now looking at the 2 major contributors to our poor NEAT, which is paediatric presentations and cardiovascular presentations, and they're now starting to look at their own little assessment units to try to move patients through a protocol-driven primary assessment by paediatricians and cardiovascular nurses and medical staff. And there's nothing to say that it couldn't be translatable into any other common presentations. So I'm not going to sing like the great man. This is Bob Dylan. And this is what 50 years of being Bob Dylan does to you, from the top left to the top right. So he is my muse, and people who know me often realise I've got to put some Bob Dylan quotes in my speeches. So for any of you trying to implement a program and innovate, what looks large from a distance, close up is never that big. So it might look daunting, but once you get into it, and if you get the team right and you work on your protocols, good things can happen. It's never as hard as you thought it was. It's easy to say it from the other end. And then for those of you who are looking for change management and trying to change the world, funny how things you had the hardest time parting with are the things you need the least. And certainly from the point of view of going from paper to electronic, that's certainly the case. and trying these different models of care where you try to move people away from emergency. So anyway, there's a great man, and as I said, I'm not going to sing like him.
Thank you. I think Sanchi is saying she wants you to sing. Or are you going to come up and sing, Sanchi?
A couple of orange juices, I will.
I definitely don't want that. It was great, Tim. Thank you very much. We're doing quite a bit of work in ED at the moment that I'll love to talk to you about.
Mm-hmm.
The question that's been asked of us is, if you do these kind of ED bypass, does ED performance go off? That is, people don't see it enough. Have you got historical ED data you can compare it with, and have you looked at that?
Well, we've only got those 3 months in 2009 in terms of timeliness in the metrics. The quality of care is a harder thing to measure in terms of adherence to protocols, but at least now we've got these protocols that are transferable, so at least they can initiate how to manage chemotherapy, diarrhoea, and how to manage radiation esophagitis.
And have they given you any qualitative feedback about whether that's supporting their practice?
Look, I think they've said that certainly it's helped them, and they're seeing less presentations to their ED. Whether it's helped the education of their staff, that's a harder one. We think intuitively, but we don't have any data to say that.
Thank you, Stephen. We'll keep going because we don't want to cut into afternoon tea. Our final speaker is Jacqueline Jagger, who's the Haematology Cancer Nurse Coordinator at Gosford Hospital. And it's great to have 3 presentations from regional centres here today. Jacqueline's going to talk to us about quality care coordination and reducing hospital admissions, the best of both worlds. Thank you.
Well, I shall tell you now I don't have any tricks or treats in mind, so please don't be sorely disappointed. And if I'd have realised there was a face-off with beaches, I would have brought a bit more to Central Coast Beach. Well, I want to talk to you today just about a programme we have running up on the Central Coast, which is a nurse-led transfusion programme, and how that's evolved over the last couple of years. And we really do feel that we are getting the best of both worlds in trying to provide pretty high-level, high-quality care alongside reducing hospital admissions. So for those of you who don't know, I'm sure everybody does, I'm the probably English person in the room, the Central Coast is between Sydney and Newcastle. We've got about a population of almost 310,000 now, 854 square kilometres, so a reasonable geographical area as many have reported today. 81 k's of fantastic coastline, and this is a picture from Pearl Beach looking over towards Lion Island. And because of that 81 k's of pristine coastline, we do have a high percentage of older population. People do like to come and retire with us on the coast. So the background to our change was because we do have a high elderly population, we get a bit more prevalence of those diseases that we see in older age. And for haematology, some of those diseases, particularly the myelodysplastic syndromes and myeloproliferative disorders, those diseases where people are starting to suffer from problems with deteriorating marrow function. What we weren't doing with this group really was managing their transfusion requirements very well. So there were lots of people with fingers in the pies with managing this group of patients. They were managed by the haematologists and their secretaries and clinic staff, the nuns in the clinics, pathology were involved. So there's lots of bits and pieces and stakeholders in their care, but not really a centralised approach to managing them. And as a result, we were getting poor chair efficiency, often people would present for transfusion and maybe they weren't very well linked in with the pathology, so from the pathology point of view they didn't need a transfusion, or maybe they'd presented to ED a week before because they were quite symptomatic and needed a transfusion earlier. So that also equated to more frequent hospital admissions and presentations to ED. And all together, you know, that just there was poorer communications between all those involved. Oh, we lost our ticks again. Sorry, this table was just all the numbers have gone. We had when we started the programme in 2009, after about 3 months negotiation with the stakeholders, we we came up with a proposal which would give the Haematology Cancer Nurse Coordinator 11 chairs over 4 clinics, and where the boxes are, that just were basically ticks where we had our clinics. So we had 11 chairs over 3 sites, and the aim was that these chairs would just be booked as a transfusion chair. They didn't have a patient's name in them. The nurse coordinator would be responsible for organising the pathology, reviewing the pathology alongside the medical staff, sorting out who was going to go in what chairs when, depending on the pathology and the patient's symptoms they were reporting back when we would talk with them about the results. So the nurse-led programme started in October 2009, and within it we built in some review processes. So at 6 weeks we wanted to have a quick look to make sure we weren't doing anything appallingly wrong, and we weren't, but the chairs were underutilised. We started off with 28 patients initially, and it just took a while for things to get moving properly, so we did reduce our chairs down to 9. The last thing we wanted to do was inadequately use the resources we'd been allocated. There were some administrative and education issues. They were really to do with things like some of the patients were required 2-day cross matches, they had multiple antibodies, and education issues around nursing staff really. They found it quite difficult to contemplate this, not really knowing who you were going to get in the chair until the day, or possibly the evening before. And just the whole way of managing this patient group differently. So there was quite a lot of education and support that needed to go on with the clinic staff. We reviewed again at 3 months and no changes were required. Things were plodding on quite nicely. And at 12 months we did a more thorough evaluation. We extrapolated pre-programme data around ED presentations and admissions, and came up with that we'd saved probably about 70 days that first year, which isn't a massive amount, but reasonable in an ED our size and with the limited oncology beds that we have. And we had about an 85% chair occupancy, which we would have liked a little bit better, but that's as it was. 91% patient satisfaction from a 65 response rate return survey. However, by mid-2011, so about 18 months into the programme, our patient numbers had peaked about 40. So I came back from maternity leave to see the rather burgeoning nurse-led programme, which was most definitely having quite an adverse effect on the Haematology Cancer Nurse Coordinator role. So, our primary remit was really newly diagnosed patients, those patients with really complex care needs, and they were really getting the bottom of the barrel from a time perspective. So we needed to sit down and look at how we could improve that situation. So with lots of consultation with all the stakeholders involved, patients and probably mainly our haematologists, we thought that the best thing to do was look at where we were making the biggest difference. So the biggest difference really was in the people who were more unwell, those who were more unstable and had their MDS had progressed further, they were into more of a end-stage disease. So we looked, and the easiest way to do it was to actually revise that referral criteria. So we did that, and the numbers were capped at 20. We negotiated for over a 3-month period for the haematologist to take some of the patients back. So anybody basically who needed a transfusion 4 weekly or more frequently stayed with us, and those who were maybe 6 weekly transfusions, 8 weekly, went back to the haematologists. They did shift our patient profile and the focus of care though, and I'll go on to talk about that in a sec, and I'll also do the results of our recent evaluation. Sorry. Thirsty work. So the patient profile, the 20 patients we kept with us were obviously more unstable. So they all had deteriorating bone marrow function, with mostly pancytopenias of neutrophil count less than 1, requiring blood products every few weeks, and nearly all of them were neutropenic. We were also monitoring this group for were there any possible therapeutic interventions, were any of them in a stage of their disease process that they might be suitable for our MDS4 trial to look at demethylating agents as a cytidine. Were any of these patients actually, if we're going to look at demethylating agents, do we need to start chelating them? What was their prognosis? The focus was very much on avoiding ED and or hospital admission, and the lots of symptom management, and for a proportion of the patients that meant was a progression towards palliation and end-of-life care. So we just wanted to, as our patient profile shifted, just to compare it to some of the other business that we do. And if on the left is our transfusion program patients, if we looked at some of the other groups of patients we looked after, it's all similar problems. I mean, haematology is haematology, and if somebody's bone marrow function is deteriorating, then there's always a set area of problems you have. So these groups of patients were also very similar problems, requiring quite intensive support as well. So those who were relapsed or refractory acute leukemia, lymphomas and Hodgkin's lymphomas, the refractory myelomas, especially those that had transformed to a plasma cell leukemia, and these people as well at the end who have been and done the whole course of chemotherapy, allogeneic transplants, relapsed after the salvage therapy. So there's a group there as well, and these people, they're quite high intensity. They've got lots of problems, multiply treated, with very poor marrow function. So these are the groups that often present to ED. Often, once they get into ED and into hospital, it's pretty difficult to get them back out again. They're neutropenic. They pick up hospital-acquired infections, and it just gets to be a roller coaster. So in December last year, we looked at, are there some exceptions to our referral criteria? Should we be looking at other patients? And we had a referral of, sorry, didn't want to do that. The ALL, press the wrong button, just an ALL patient who was relapsed refractory post-allogeneic transplant, and really where did we sit this guy? He was our business anyway. He was somebody who we would look after, but by putting him into the transfusion program, it meant that he had that level of monitoring that was very close. He had the nurse assessment, he had the triage. So we started with him, and today these are sort of the other patients we've had which don't meet the original criteria. So again, relapse refractory, all these patients. This young girl has now gone off for her BMT, so it was just intensively supporting her while she was getting a donor, basically. We've got, we've had a couple of plasma cell leukemias, an allogeneic relapse, an adenocarcinoma of unknown primary, which, poor guy, nobody else would look after him because he didn't fit a tumour stream. So we looked after him until he died, and then people who are in between relapse and BMT, so while they're being worked up, they've often got a reasonable requirement as well. So just for a case in point really is Stephen. He was a cursed boy who was diagnosed with ALL at age 4. He had BMF protocol chemotherapy, which is a 2-year chemotherapy. Unfortunately relapsed in 2007 and had further chemotherapy for that, some salvage chemo, and however, he remained minimal residual disease positive after chemotherapy. 2008, he had a sibling allo BMT. Unfortunately, August 2011, excuse me, he had his second relapse. He underwent donor lymphocyte infusions and salvage chemo, but he remained refractory to treatment. He also had a pulmonary invasive fungal infection, which was causing quite a few problems. So at that point, it was decided that he would be transferred back up to the coast for palliation. So it was this guy, as I say, I'm discussing with our haematologist, it was felt that he really didn't need that extra support, and maybe just to put him into the transfusion programme so we can keep a close eye on things would be the best place for him. And he died in June this year, aged 21, but the interesting point, apart from obviously what the poor guy went through, is the fact that this was actually his first admission to hospital. So we managed to successfully keep him out of hospital from December 2011 till the day he died, which was quite an achievement really, because he did not want to be in hospital. Sorry, we have a problem at this point. I have to keep pressing the button. So just a very brief evaluation to date. This evaluation is 2 years and 7 months. The only reason we haven't picked a round number is that we're trying to collect these the feedback from the clinic to present at our annual scientific meeting, and also for funding. So we've had 44 patients over the last 12 months. For those 44 patients, there's been 86 admissions, 16 associated with anemia, but only 6 of those were directly, purely for transfusion. 3 were anemia related to disease escalation, and 7 were sepsis or PR bleeds. We've had a fall in the chair usage of 81%, which was a concern. And when we looked into that further, we've had, there's probably a couple of reasons for that. We've had maternity leave, and it took a little while for the replacement just to get to speed. So some patients, the chairs weren't accurately used for a little while. And also I think it's reflective of the extremely instability of this group of patients. 93% patient satisfaction, that's actually gone up because we've just got a couple more surveys back. So it's probably, I think it was 96% now. And as you can imagine, 100% haematologist satisfaction, because the patients are highly satisfied, and it's just helping them with a particularly unstable group. And I think the question remains to be asked about, is it an appropriate use of a cancer nurse coordinator? We've certainly been asked that question up in Gosford. You know, really, is this your job? Should you be doing that? Well, actually, there's nobody else to do it, but we do feel very strongly that it is an appropriate use of the nurse coordinator. So I've just tried to portray in this slide what the coordinator does for the nurse-led programme does fit in nicely with the roles and responsibilities of a cancer care coordinator. You know, there's lots of lead clinician. Our lead clinician is a haematologist, so there's an awful lot of collaboration in that degree, and also our collaboration with BMT and everything. Lots of psychosocial and physical triage, coordinating patient care, lots of MDT support. We've got a fantastic MD team up on the coast. They all are dragged in to see our patients, and our education and training is relevant to the role, and programme info and resources are embedded. Sorry, and that's it. Thank you.
Sorry,
it's an awful lot to get in 12 minutes.
Just a bit of pressure to finish quickly, because we've got the debate coming up and awards of prizes and so on. Unless anyone's got a pressing question, we might have to stop, I think.